Welcome, everyone. It is so lovely to have you all in this virtual room with us today for this really exciting discussion and very pertinent, of course, with the times that we all are, I'm sure, following in the news, just watching unfold. I will just take a moment to introduce myself before we dive into discussion. My name is Rashmi Krishnasamy, and I'm currently a third-year osteopathic medical student at the A.T. Still University School of Osteopathic Medicine in Arizona. I'm currently based out of Chicago, completing my clinical rotations at Strodrico County Hospital. And I guess as far as my background with SMA, I served as the founding co-chair of the Social Mission Alliance's Advocacy Advisory Council. And I also led some of our student assembly initiatives, which are now more familiarly known as the learner engagement initiatives. And then the other hat that I wear is I currently serve as a national parliamentarian for the Student Osteopathic Medical Association, which is the official arm of the AOA. But tonight I'll be serving in my SMA capacity to moderate this discussion. So as you all know, this webinar series this webinar tonight is the first of a webinar series. It's a continuation of our Student Assembly webinar series initiative. Tonight, we're going to be talking about just the health workforce pathway specifically, and our title is Dismantling the Health Workforce Pathway as it relates to the current policy changes that are being discussed on the federal level. So as I mentioned, these webinars used to be a part of the Student Assembly, but now that initiative is being transitioned into our learner engagement initiatives. And these webinars are really to serve as a forum for health professional trainees and other lifelong learners who are at varying stages of their training to really engage in dialogue on issues that are very intimately impacting our health workforce and health professions education. We really hope that this forum can continue to allow for greater perspectives from the community, from patients, educators, and just leaders and learners from across the spectrum to really fuel change that unites all of us so that we can continue to advocate for positive change within the healthcare system. We really hope that this transition from the Student Assembly to learner engagement is going to strengthen the connections across our Social Mission Alliance community that are really necessary to realize the collective vision that brings us all together while maintaining a home base for student activism. So that's just kind of our intro to our series overall. I'm going to take a moment to introduce our amazing, amazing speakers that will be with us tonight for a discussion. Starting off with Michael. Michael Green is currently a candidate in population health sciences at the Duke University School of Medicine. Harold Baker currently serves as deputy director for the Summer Health Professions Education Program at the Association of American Medical Colleges, AAMC. And Basharia Keys is the Vice President of Policy and Regulatory Affairs at the National Association of Community Health Centers in Washington, D.C. I know I didn't do justice to the three of you. You guys have done really amazing work. Their bios will be circulated if they have not already been made available to all of you as attendees. But please do read up on these folks' work when you do get a moment. They have done such incredible advocacy, and I'm really, truly excited to be moderating the discussion with them this evening. So I know we talked a little bit about the topic already, but I guess more specifically, this conversation is going to be highlighting the impacts of federal policies on both the future of health workforce in the country, that as well as the potential impact that this has on healthcare access for our most vulnerable communities and what we can do now to prevent it. So we're going to be talking tonight about the various funding sources that have been impacted, so financial aid caps, grant access to trainees, and just cuts to overall things like Medicaid and Medicare, and how they've historically helped the workforce and how now this is going to impact the country's most vulnerable populations. So that being said, I'm going to spend a brief few minutes sharing some of the work that I've been working on in the osteopathic world, and as well as just kind of discussing the impact from what I've seen and just kind of heard in this medical student world about HR1's impact on students. Some of the really salient topics that have been coming up, as we can all imagine, is the cuts to I don't want to say direct cuts, but the uncertainty around student loans certainly is making it difficult for students to focus on just their studies. I think all of us are very anxious about what the heck happens if we complete school and then these loan programs are no longer made available to us. Things like public service loan forgiveness is kind of like a security blanket for a lot of us that are in school right now. to really, it really has served as a tool to allow us to complete our education without fear of having to drop out due to financial concerns. And now I think that is very much on the table as a lot of my classmates that I've been thinking about, like, what does this mean for the sustainability of our education as we complete it? And then what do you do when you're already kind of in debt? And what does that mean for paying those loans back? Not only is it impacting the students as a community, as the folks that are currently in school, it's also really stirring up, as you can imagine, a lot of anxiety amongst incoming students as well. Folks that have been admitted to medical school and other health professions institutions are now kind of reconsidering that, is this a time for me to go to medical school or not? Which is truly a really unfortunate kind of position that our trainees are in, especially given our health workforce shortage in a lot of ways. I myself being at a school that really emphasizes primary care and just kind of understanding the implications of where the primary care workforce stands right now, that, as you can all imagine, is a very detrimental kind of position to put our trainees, given what could happen coming down the pipeline with the health workforce. Outside of kind of those direct impacts to the student loans piece of it, the other thing that is really coming up in student communities is the conversation around Medicaid specifically, which, of course, I think traditionally a lot of folks think about Medicaid with, of course, patients being able to access care. But this is also something that, sometimes students, when they're enrolling in medical school, end up enrolling in Medicaid in their state, because that's often cheaper insurance than whatever their school's offering them. So student community is also very much impacted by these Medicaid cuts. And that's another big kind of piece of the conversation that's been happening. And of course, all of this anxiety and the turmoil around these federal changes are certainly impacting students' ability to perform academically as well. So these are kind of the challenges that I'm sure a lot of folks kind of could anticipate that amongst the student community, but I wanted to reiterate those here. And I will quickly, I know I want to allow time for our wonderful speakers to kind of jump in too, but I'll quickly kind of mention some of the things that are happening in the osteopathic world that are kind of combating these or kind of trying to advocate for this. So one big update from our AOA the Summer House of Delegates back in July is we passed a resolution H634, which basically calls for the AOA to work with relevant stakeholders to advocate for appropriate low-cost government and private loan availability, and to ensure that that kind of remains available for osteopathic medical education. So what this does is basically tells the AOA to continue advocating for the loan availability despite what happens on the federal level. And this kind of was a message to our student community saying that, hey, the AOA is doing the best that they can to support access to the loans, regardless of what happens. And they did kind of mention that they're going to try to work with both private stakeholders as well as federal, like low-cost government stakeholders as well, because we don't really know what's going on the government side. So if we can, at least the private companies, it could provide an opportunity for them to be take hold of this issue in a different way, which sure has its implications, and I'll let our speakers kind of speak about that. But that's one thing that the AOA is doing. And then we did pass a resolution from our Student Osteopathic Medical Association just last weekend, actually, that basically captures the impact of the HR1 on medical students and gives us, as the Student Osteopathic Medical Association, a little bit more teeth to kind of advocate on behalf of our student community against some of these policy changes that are occurring. So I will pause there, and I'm going to kick it over to Harold. Harold, please feel free to take a moment to introduce yourself and kind of provide a little bit of context on the work that you've been doing. And then if you could also elaborate on the work that you've been doing supporting SHPEP and the pathway programs that are like it.
Sure. Thank you. And good evening, everyone. So my name is Harold Baker. I serve as Deputy Director for the Summer Health Professions Education Program, otherwise known as SHPEP or SHPEP. It is a free summer enrichment program for rising sophomores and juniors. So we're at the beginning of the learner pathway to becoming physicians. And this program has been in existence for over 35 years. It began as the minority medical education program, then it became the summer medical education program, then the summer medical and dental education program, and most recently, the summer health professions education program. And in its current form, we not only work with students who are interested in going to medical school, but also dental school, as well as nursing, pharmacy, physical therapy, public health, several of the health professions. And so our goal is to ensure that students are well prepared to apply to successfully apply to health profession school. And the program has had a very long and intense relationship with SNMA. And so we're really proud of that relationship and very happy to be here today. And so as far as the work that we're doing in preparing students, I think part of the secret sauce of SHPEP, as many people refer to it with the acronym, is that we provide students with mentorship at all levels. And so that a 6-week summer period is very transformative in their lives, and they're able to connect with not only a cohort of students who look like them or from similar backgrounds, but also they're able to connect with faculty, deans, and other leaders in academic medicine who want to help them along that path. And so it's really exciting for us to continue to be that entry point into the learner pathway for physicians and other healthcare professionals.
Thank you so much, Harold. And can you speak now more specifically to how the caps to financial aid and anti-DEI policies are going to impact pre-professional students, that are supported through programs like SHPEP, and how, SHPEP can maybe kind of help mitigate some of these effects that we might be seeing on the federal level?
Yeah, it's definitely something that we're dealing with currently, and I know all of us have, and it's a difficult time. The biggest challenge we feel is that students who are from under-resourced communities and students who maybe are afraid of taking on debt for health professions, they are definitely afraid within this new environment because of the caps that you mentioned to student loans and other adverse impacts of the legislation that has been shepherded by the current administration. And so at SHPEP, we're really dedicated to ensuring that our students have the latest information on financial aid. And we actually do in the summer a 2-day session on financial literacy. We call it the Financial Literacy Planning Workshop. And we have dedicated financial aid experts from usually health profession schools. So they are very familiar with the terrain, and they can help students better plan for how to manage their health professions education and ensure that they get the proper scholarships and loans that will ensure that they don't have a tremendous amount of debt. And so that's something that we've done since the beginning of the program, because we recognize that students from those under-resourced communities, the biggest fear in going to medical school is how to afford it. And so we want to make sure that they understand that there are ways. And in this current environment, it's having a adverse impact. And so we want to ensure that they understand the ins and outs. And our financial literacy planning workshop facilitators are experts in their field. And so they can help give them the latest information that will ensure that they can afford to go to health profession school.
That is really amazing that you all are able to, carry out that work to especially educate our learners about that, because that's absolutely something that we're seeing in the osteopathic field too. And I think A lot of comms are now starting to put out that information as well. So it sounds like that's a strategy that, certainly is meeting the learners where they are, while also kind of trying to be, realistic about what it actually is happening, while validating how folks are feeling. So that is, that sounds really amazing. And hopefully our team can follow up with you about some of those resources, and perhaps we can share some of those resources with our own learner community, as I'm sure they have tons of questions about this as well. Thank you so much, Harold, for sharing that. Michael, I'm going to kick it over to you for a little bit. Feel free to also go ahead and introduce yourself, and then speak a little bit more specifically about the work that you do at Duke, and how the terminations of NIH grants are specifically impacting researchers like yourself right now.
Yeah, thank you for the transition. So I'm Michael Green. I'm, again, a PhD candidate at the Department of Population Health Sciences at Duke University School of Medicine. And I'm specifically focusing in my own research on discrimination in healthcare settings. And so I think I have a broader kind of research agenda that is around health equity topics, specifically thinking about a lot of the different social factors that impact someone's either desire to seek care, or maybe even some ways that that they receive care as well. And so I think that is something that's really important to kind of note, because I think that that's something that has never quite been easy to pursue as a research agenda. And I think now more than ever that it's something that's under siege. And so I think from my own experience, I can kind of talk about how I'm now a fifth year PhD candidate who's hopefully actually going to graduate some point at the end of this year if my committee gives me the blessing. And so I can speak a little bit more in like a kind of backwards looking fashion here. And I feel like I was very privileged to have a lot of different programs kind of supporting my work through time. And so thinking about at the end of my first year, I applied for an NIH diversity supplement program, which is now a program that no longer exists. And essentially the diversity supplement program is a program where you could supplement existing research grant at your own institution, carve out your own basically research question that would be under the guidance of someone who is already working on a project. And so in my case, my primary advisor or mentor, Matt, he was working on a project looking at how different social factors impact risk prediction for cardiovascular disease. And so I carved out a question underneath that, looking at how discrimination in healthcare settings impacts some different risk factors along those risk prediction models. And so it was a very beneficial experience for me, because one, it kind of freed up my time to create my own study, learn about the grant writing process, and work with someone who didn't necessarily have the funds to support a student. But because of this program, I was able to kind of gain a kind of rock solid mentor in my own life who's been a very good advocate of me. And so I don't want to get into the weeds of what that program actually looked like, but again, I think the key kind of takeaway there is that it gave me the ability, the grant writing experience, which is very essential at different schools of medicine. If you're pursuing it, a career in, I guess, academic research as a PhD student. A lot of these places run on soft money, which essentially means that you have to have grant funding to kind of cover your salary effort. It's not necessarily just about teaching. It's usually a combination of both teaching and research efforts. And then it also provided me preliminary data for a even larger fellowship, which was a pre-doctoral to postdoctoral fellowship, which I think it's a very unique kind of program. I think that only a few of the different institutes at the NIH did, but it's kind of almost I would think the ideal launch point for someone at my stage, where you get both pre-doctoral and postdoctoral funding to kind of develop your own independent agenda before you go on to be academic faculty. And so I guess thinking about, I have not had any grants personally terminated, because the program I'm in right now, it's a program that was not under one of the kind of parental diversity awards, I think is how they were calling it. But I must say that my research topic has been dramatically affected. And I think this is well covered up to this point. I was requested to entirely rewrite my proposal, and at the progress report, rewrite the progress report itself. And so I'm happy kind of afterwards to kind of send a few news articles to kind of describe the implications of this all. But this is not something that's happening equally. So some topics themselves are now being considered not, I don't want to say not legitimate science, even though that's how it feels like some of the communications have been towards us, but that they are no longer institutional priorities of the National Institute of Health. And so it's something that's kind of like whiplash, where I came into the program in 2021 when a lot of different, I guess, institutions were talking about how they really have a serious commitment to health disparities, improving health equity, and there were programs that were expanding to specifically help students like myself. And now at a point in time where someone like myself feels that I can like kind of reap some of the training that I've gotten up to this point and maybe provide some wisdom to the students within my own program, individuals who are prospective students, a lot of those programs are kind of going up in smoke right now. And so it's very troubling times, but I definitely think that I got into this program to impact my field, not necessarily just chase grant dollars and write manuscripts. And so I'm still hopeful about the possibility for kind of positive research change in the future. Is that a good overarching statement?
That is perfect, Michael. Thank you so much. I'm going to ask, a little bit more I guess, to dig deeper on some of what you said. So I know you mentioned some of the impacts that a lot of this is having on your work and kind of the field overall. I'm curious to hear if you've seen any advocacy initiatives or if you yourself have been a part of any initiatives that kind of prevent some of these funding changes that we're seeing. And I know it's hard to kind of necessarily control the language that the administration might be putting out about some of these topics, but just curious to hear about any advocacy initiatives around this issue.
So prevention is probably a little trickier than necessarily kind of information sharing, which I think has been kind of the primary stage we've been at right now. I'm aware of a few different initiatives. I think it's called like Grant Watch right now, where there have been a lot of kind of self-reports of if you have grant terminations or if there's kind of any kind of I want to say if you are requests are made for your actual awards, I think there's been a lot of kind of public kind of surveillance of these different requests that are going out to scientists. Because again, this is very abnormal. Like in the past, like a grant will be terminated if there's like an adverse event in the study, or there's like let's say something like plagiarism or something that's seriously like kind of academically problematic. Not that all of a sudden the administrative priorities change, and so grants are now retrospectively being told that they're no longer valid. There have always been kind of ebbs and flows of scientific priorities. Like let's say if someone a new administration came in and then their research agenda, they wanted to change and focus on, I don't know, healthy eating for kids. That is something where they could open up special opportunities. And that is kind of traditional. Now, what's happening today is very abnormal. And I think that's something that a lot of people are just kind of understand the gravity of all of that. I have seen a few different organizations who are kind of trying to open up some of their opportunities, whether it be different scientific foundations such as the American Heart Association or maybe the Robert Wood Johnson Foundation, who are opening up special calls for individuals who have had their NIH grants terminated. And I think that some individuals have gotten through those to varying success. And I think that a lot of, honestly, it's kind of been, from my observation, very institution by institution in terms of the support that they give to both the students and the scholars to kind of participate within advocacy as well as kind of public communication around some of these things. And so I've kind of always felt that traditionally a lot of our guidance on like kind of speaking about our scientific process was you don't really need to go into social media. If you go into the public, like you need to kind of have a very kind of buttoned up presentation of your work. And I think that with the reality that if people who are training to become experts or are currently experts are not out there, there's going to be a void that is going to be filled by people who might not necessarily have the same background and training as you. And so I've actually noticed quite a bit more encouragement, not only from, I guess, mentors, but also from just science communicators in general to kind of go into different spaces and talk about their own work, kind of, and even some of the in the weed stuff about like how research even happens, what are taxpayers' dollars going to? And so that's more what I've noticed. I will admit, I haven't seen a ton of prevention efforts in terms of necessarily bringing back funding, but I think that a lot of both public health, population health sciences, and other health sciences researchers have kind of heard the call that we've lost a lot of trust within research. We're thinking about ways to kind of communicate the impact of our work and kind of hopefully have individuals understand that what we do is important and a kind of vital part of progress in our society.
Thank you, Michael. Yeah, so it sounds like, a lot of your advocacy, it sounds like it's centered around kind of educating both just the general public, but also just, folks that are taxpayers, right? That are, feeding into or paying into essentially, and just contributing to like research in general in this country and kind of making sure folks understand what that looks like. And it sounds like just from what you mentioned and Harold, you mentioned, it's hard to necessarily, I guess, preventatively advocate for some of these things, but it sounds like the key to a lot of reacting to some of the changes that are happening are very much within the realm of information sharing and making sure that folks are able to access the information that they need to in order to make informed decisions about certain things, or just understand some of these landscape changes that are happening. But Sherry, I'm going to kick it over to you to speak a little bit more about your work. And just like Michael and Harold, please do feel free to introduce yourself and kind of expand on the work that you're doing. And then specifically talk about what you think the impact of HR1 is going to have on patient care in this country, especially for the patients and communities that NAC serves.
Yeah, so thank you for having me. I'm Bashiri Keys. I'm the Vice President of Policy and Regulatory Affairs at the National Association of Community Health Centers. So community health centers, also known as federally qualified health centers, are federal grantees. And we are required to serve everyone, regardless of their ability to pay, as well as being located in medically underserved areas or serving medically underserved populations. So there's a lot of, you could say, specialty health centers that serve patients that are experiencing homelessness. We have migrant and agricultural health center focus. We have LGBTQ health centers as well. And we also have health centers that do public housing specifically too. But about 50% of health center patients are on Medicaid, about 20% are uninsured. And we definitely do see, we see everybody who walks through our door. And so the federal grant allows health centers to really serve those uninsured and underinsured. We also provide medical services on a sliding fee scale to help with that affordability. And so since COVID, health centers have definitely been struggling to keep up with the pace of healthcare inflation, which I think is plaguing, hospitals as well, and rural health clinics and everybody in between. But definitely the impact of HR1, we will feel it because of the different provisions that impact Medicaid access. So I say we advocate from two ways. We advocate for the patients that, come to the health center and rely on the health center to have access to affordable and quality and respectable care. And then we also are advocating for the health center themselves as an entity and the safety net provider. And so HR1 has impacts on both. From the provider perspective, the law impacts who is eligible for Medicaid, and then also directing states to have more frequent Medicaid checks, eligibility checks, which we know from the unwinding of the COVID-19 pandemic, there was a lot of churn of people who were eligible and should have maintained coverage. And so we're definitely concerned about how that Medicaid churn will happen as these new provisions go into effect between pretty much 2026 to 2030. There'll be something new happening in the Medicaid program. And then the other piece that kind of will impact our patients is around immigration, and not really focusing on just, the changes around undocumented patients, but really about who is able to have Medicaid and Medicare coverage, who are legal qualified aliens is what the phrase is, or the term is. So really, there's a lot of changes of how people are going to be able to enroll in Medicaid, what is required for them to stay on Medicaid, and then also just that eligibility category will change as well. But there's also other provisions around like the financing of Medicaid that will have a huge impact on state budgets. So I think something that's unique to healthcare and really thinking about Medicaid is this partnership between the feds, the federal government, and the state government. The state government relies heavily on the federal government cutting their check and carrying their portion related to healthcare. And so a lot of the changes around state directed payments, provider taxes, different ways that states partner with the federal government to receive their fair share to fund their state's healthcare program will be eliminated or really severely dwindled down over the next 5 years as well. And so, it's still the same pot of money, but now it is going to shrink. But it's still the same amount of players, it's still the same amount of need, and the state still has to, most of the time, keep a balanced budget. And so these changes in the state healthcare budget are also going to have impacts on Medicaid eligibility and provider rates, because unfortunately the state is going to have to make cuts to be able to implement a lot of these new changes, but then also to cover other things, right, that the federal government used to be able to cover that maybe they're not. And so for us as a provider, we are very concerned about the impacts to state loan repayment programs, state workforce initiatives, partnerships that health centers have with the state to try to take the burden off of the state, but also making sure that the patients that are maybe right on the cusp, if folks, are aware, like, you don't have to be rich to phase out of being eligible for Medicaid. A lot of those federal poverty levels are, people making less than 20,000, 30,000, which we all know in today's America is very difficult to feed yourself or your family off of. So we know that we see a lot of patients that are right on that cusp of will they be eligible or not? And then also, I forgot to mention, like, the changes with the marketplace. So for folks that aren't eligible for Medicaid, the marketplace and the premium tax credit is something that hopefully will get addressed this year before it expires. But just naming all these different changes, right? It really impacts the who depends on us, and then also educating those folks, right? And so I think a challenge that health centers have are, we feel like we're kind of financially drowning, really stretching our scarce federal resources, but then still having to meet this demand of seeing whoever walks through our door. Something else that is just also in the background for health centers as we talk about a government shutdown that is looming in a few hours is that we've been operating off of a continuing resolution for the last 3 years. So the health center program has not been officially authorized, and Congress kind of keeps kicking this can down the road. And so we've been advocating to increase our federal grant for a lot of the things that we're talking about, but definitely knowing the impact that HR 1 is going to have over the next 5 years and the patients we serve and the dollars that will be able to come in the door if there's more uninsured people and less people with insurance. We're really hoping that Congress invests in community health centers so that we can continue to serve patients, expand access to primary care, but health centers also provide behavioral health services, maternal health services. We also address the social determinants of health that Michael was talking about. It's very hard for someone to come in for the doctor if they don't know where they're going to sleep, what they're going to eat, or how they're going to get their kid to school. And so, it's a lot of things happening at the ground, and they're all kind of happening at the same time. So community health centers are, they are scrappy, they're strong, they're resilient. But at the end of the day, we do need money to keep our doors open. And I think we're, making sure that health centers are working very closely with their state governments as they're making difficult decisions to really understand, why it's important to invest in health centers.
Thank you so much, Sherry. That was a very comprehensive kind of overview on the things that you've been working on, as well as some of the actual, tangible impacts that these changes have both on patients and communities, but also, health centers in general, and a little bit about on the workforce. I do want to dig a little bit deeper on the workforce piece of it. Could you share a little bit about, maybe some of the advocacy efforts that are going into really protecting community health centers' ability to kind of recruit and hire staff in the face of these changes around loan forgiveness? I know I'm a student at AT Still, and we actually go to community health centers, and that is something that we've been talking about is, how do students like myself continue to serve patients in these communities when, one, we love doing it, but two, like, patients need a workforce to continue to serve them. So curious.
Yeah. Some of the unique loan repayment, like the National Health Service Corps, that also is up for reauthorization as well. And we are also advocating for an increase in that loan repayment, because that really is a huge recruitment tool for health centers, and being able to offer folks, especially going to more remote areas, more rural areas, to be able to offer them loan repayment and have that unique opportunity at a health center. Something else that we are trying to advocate for and point out on the state level, there's a lot of state-based workforce initiatives. And so we are hoping that those aren't the first to go. And so it's really, this is an advocacy opportunity for everyone, right, to get involved at your state level with your state associations, your state chapters, because you want them to understand that investing in the workforce, investing in loan repayment or pipeline programs, trainings, fellowships, that helps strengthen the overall healthcare, workforce in their state. So it could feel like a very small initiative to your state or your governor, but you really have to do that advocacy to educate people on the investment today will return in 5 years, right? Or 3 years. But also, if there aren't those opportunities, people will come to your state, go to med school, and leave. If there's no opportunities for those folks to stay. I think the buck is really going to stop at the state level. HR 1 passed, Congress has decided that bill's not getting undone as much as the Democrats would love to see that. There's a lot of decisions that are going to the state level, what states are going to have to decide over this budget season and the next year. And so you want to make sure that they understand, right, what these loan repayment programs mean, what does investing in the healthcare workforce mean for your state, because those are some of the consequences that people will come and go because the state doesn't offer the best resources for folks.
Yeah, you're absolutely right. And thank you for kind of expanding on that and covering kind of the different levels of advocacy. I think it's really easy to kind of get wrapped up in, all these changes that are happening at the federal level and really hone in on the national, federal advocacy that we can do. But you're absolutely right. Like states are such a really strong microcosm in and of themselves within each state. And there's such, opportunity for folks to get involved and really advocate at their own state level. So thank you for highlighting that. I'm going to pause with our, moderated discussion here and kind of open it up to the audience to see if folks have any questions for any of our panelists and speakers here. And if you do, go ahead and either drop it in the chat or go ahead and come off of mute and feel free to ask your question. And if there are multiple people that kind of come off of mute, feel free to raise your hand and I'll call on folks.
I have a question, really in follow-up to Visharia, what you mentioned on state level opportunities for advocacy relative to loan forgiveness programs. Is there any organization or any like resource that you're aware of that can like highlight state level loan forgiveness programs that people should be watching out for or advocating for?
Yeah, so I say your like state provider association, like whatever your specialty is or wherever you're working, so you could get involved, right? At your state hospital association, if you are trained in a health center, at the primary care association, or like your local AMA chapter. There's a lot of different national associations that have local state chapters. So I think whatever you're kind of focusing and honing in on, as a person that works in association, there's an association for everything. So it's no shortages of associations, I can tell you that. So I think kind of find where your people, right, who focus on your piece. And I think every type of healthcare association will be focusing on workforce. And I say there's probably a bigger push in rural areas as well, too.
Thank you, Visharia. There is a question in the chat from Emil. And the question is, are you seeing any new discussions about specialty or career choices changing due to concerns about future debt? I think this might be more geared towards Harold, but open to any of the panelists here.
So I can start off for sure. I know that, as I mentioned, the Summer Health Professions Education Program works with students at the undergrad level as they're preparing for health profession schools. And a lot of the students that we've talked to, before wanted to do primary care. And I think that could change based on, what we've talked about today and what's going on with loans, because students are very financially sensitive. And so if there's a way to make more money in a specialty as opposed to doing primary care, even though their heart and their soul is in primary care, that may impact that decision. So I hope that we can continue to help students see opportunities to continue on in primary care pay off their health profession school loans and have a thriving life as a primary care professional. Because as we all know on this panel, there's currently a shortage, and it's only going to grow, particularly for minoritized caregivers.
Michael or Sherry, do you have anything else to add to that?
Oh no, I definitely agree. NAC is definitely invested in trying to get more support for primary care providers for simply what Harold mentioned is that, if you want to go be a family practitioner or do primary care, the incentives, especially looking at some of your colleagues who go to specialize, it makes you kind of question your choice. And so we definitely have a lot of initiatives about increasing the investment in primary care so it can provide that same lifestyle or appeal as people are going through their medical school journey.
And I can't necessarily speak to the medical school side of things, but I can to just a general graduate education side where I think things have been tough because a lot of programs have had to cut back because of the funding cuts. And so a lot of like incoming PhD classes, like people are either not taking any students or indefinitely suspending any acceptance of any applications. And then I think that you have to think about the kind of downstream effects of that as well in terms of, well, for master's programs, where it be master's in science, master's in public health, which are often kind of either programs where individuals can kind of pivot or transition to a different kind of part of the career or use it as a stepping stone towards a PhD. If there aren't any PhD programs accepting people, I think a lot of people have kind of second guessed their decision to maybe put in an application for that in the future as well. And so I think that even it's a kind of it's a systemic issue where if you can't support PhD students, if you can't bring in new faculty members, it really kind of favors like incumbency. And so, like for the individuals who have maybe already established themselves, I think that it's already hard for them. And for a lot of the individuals who are just trying to find out what's going to be their next step or next stage, it's pretty murky water, to say the least.
And I'll jump in and add, the medical student perspective a little bit. I will say that there are quite a few of my peers are kind of thinking about that, right? Of, primary care is not necessarily the most lucrative field, even if your heart is in it. Now, I will say I'm at a school that really emphasizes that, and our partnership with NAC has been really fantastic. And I personally feel like it's been a fantastic fit for me. And I still want to do primary care, and I'm like, I'll figure it out. I'm hoping the pendulum swings the other way, and within the time between now and when I graduate. But my heart is in primary care, which is why I went to medical school to begin with. But there are, some of my classmates are rethinking that decision to go into primary care, and some of my colleagues just in the osteopathic profession, which is a shame also because the DO workforce has historically been very much geared towards rural and underserved communities. So that is something that the profession is kind of thinking about as well. The other thing that's kind of been a lot of incoming students' minds of, folks that got into medical school, but are now thinking about, do I want to take this offer to go to medical school? Because it's one, really expensive. And two, if I don't have that financial security to make sure that I am kind of, I can actually submit my FAFSA and get whatever support I need to for the entire 4 years. And I don't know if I actually can afford to do this for the whole 4 years. So we are kind of starting to see some of that hesitation and potential kind of pivoting into other fields, both within medicine and outside of medicine. There are folks that are considering, PA programs or shorter health professions trainings programs to still allow for them to be a provider in some capacity, but maybe not, doing the entire 4 years of medical school per se. But it's a little bit of everything. There's a lot of hesitation, a lot of uncertainty. And I guess we won't really see the impacts of what that looks like on our workforce until a few years down the line after all these changes kind of really settle, if you will.
Yeah, I think it's a famous quote. Maybe Charlie Munger said, if you show me the incentives, I can show you the outcome. And so I think you are seeing a lot of that right now, where it's kind of like if you're changing a lot of the things kind of about how we educate individuals, and then not really changing the incentive structure around it or necessarily the opportunities that are available, I think it's almost inevitable that you're going to have the workforce dramatically disrupted in the kind of pathway. And I think that that is one thing, but I think that's quote still kind of remains for when you think about solutions for the future. Again, if you show me the incentives, you can show me the outcome. I think there's a way to kind of think about ways to either re-entice people, give people a feeling of maybe future stability, or maybe rethink what is possible after all this kind of chaos and instability. And I think definitely where I'm trying to kind of focus a lot of my time, energy, and efforts now, because I think that like even during times when you're kind of faced with kind of unreal uncertainty, I think that as a scientist, I always have to kind of skew towards optimism and think about things and kind of the long-term vision of progress. So that's another point as well.
Thank you so much for mentioning that, Michael. And I honestly, I feel personally optimistic about just, the people that we have in this room, the brains that we have here to kind of, we have folks from the different parts of just healthcare and health workforce research. And I think this space is rare sometimes. I think it's very easy to kind of get wrapped up in our own silos of working together. So I agree. I think there is, lots to remain optimistic about. And it sounds like there's a lot of energy around just advocacy, because there is an absolute need for advocacy right now, which in and of itself, I think serves as a point to be optimistic. And at SMA, we're happy to kind of support and facilitate a lot of those discussions and do resource sharing and whatever we kind of need to continue building upon this energy, because we need to be working across different sectors, across different professions, if we really want to kind of bring forth this change and advocate for the right thing, especially right now. I'm going to pause for a second. I know, Toyisha, you came off of camera, so I'll open the floor to you for a moment if you want to come off mute and say something.
No, sorry, I didn't actually have a question or comment, but well, since I'm
sorry to put you on the spot.
No, it's okay. I'm thinking about some of the different points that are being brought up, and I'm curious to sort of know from others. And I see that Emil is in here. I know that you dropped something in the chat earlier, but I'm kind of curious from your perspective on. I'm actually curious, from others on what you all think is the, as Michael had kind of mentioned around like the role of incentives and how that will draw and drives some of the outcomes that we'll see. What folks are seeing from other vantage points. So I'd be curious to know if others can offer any perspective from your points of view.
I can jump in a little bit here. I think a big incentive right now is kind of leaning on the power to the people, if you will. I think a big part of what I've been trying to work on, at least in this like osteopathic student community, is ensuring that our students feel equipped with the resources to feel empowered to use their voice. All these issues are affecting us so intimately, and I think sometimes it can feel that students' voices aren't always heard, and now is a perfect moment to use that. And I think the way to kind of do that safely, especially during a time where individual voices can be silenced, just with the way that the landscape is unfolding, I think organizing and doing it in a group, or there's power in numbers too. I think that's kind of something that I've been really pushing to our student communities. I think that there's also major incentive for just patients to be involved in advocacy. And of course, that comes with asterisks as well, because certain patient communities are more vulnerable than others right now in terms of utilizing their voice and being able to speak up and feeling empowered that they can speak up without fear of retribution or harm in any which way. But I do think that, at the end of the day, these systems changes, sure, definitely affect, certain groups over others. But at the end of the day, I think everybody's impacted by them. And I think that, those that may be less impacted by them can and should utilize their voices so that we can really change the system for the better for everybody. So I think this is the incentive is that the system isn't working, and there are many people that are affected by it. And I'm hoping that we can empower folks to just utilize their voice in every which way, whether that be at the state level or the federal level, or within their institutions as well, because it's really important.
Yeah, no, thanks, Rashmi. And maybe I you got to the point that I was trying to make without me actually articulating well what I was trying to say. But I think the question that I'm even really curious about is really around narrative development and what are the different forms of, as you kind of talk about these different possible levels of impact and this sort of broader statement of potential impact that isn't specific to, this is the idea of pathways as a form of raising all boats, if that saying is correct, right? This idea of being able to, this is a net positive for community health. This is a net positive for population health. Um, I'm curious as to how we can, from different organizations, different professions, find a way to develop narrative that sort of seizes on, the incentivizes the public good, and how can we really leverage each of our individual positions for sort of this collective vision of a population health improvement, given the fact that different factions of people, different organizations, different institutions, different systems are going to be moved based on different types of arguments and different types of narratives. So that's the question that I.
Yeah, I can chime in. I think
Yeah, please.
that you have to speak the language of the people that you're trying to motivate. And so, even though, or I will say that, health centers might have some different priorities under the Trump administration, but at the end of the day, there are things that we need to get done for the people that we serve. And because regardless if it's a Republican or a Democrat, like health centers will be here. We've been here for over 60 years. And so it's really about how do you meet people in the middle, and you're advocating for one thing, but you have to say it in 5 different ways. And so it's really being able to understand the audience that you're trying to influence and trying to educate a family member, right? A friend versus like if you're going to a state hill day, you're talking to state legislators, or you're going to a fly-in and you're coming to DC to meet with members of Congress, or you're trying to work with other medical professionals that maybe don't do the work you do, and you're trying to get them to see the value in serving more uninsured or inserting themselves in areas that maybe they're not comfortable. So it's really about learning the audience that you're trying to speak to, what are their priorities, and then how do you make your priorities sound like theirs. And so it's really learning how to speak the language. Like, for instance, this Trump administration does not believe that the HR1 implications are going to have less people on Medicaid. They don't believe that's true. Literally. Doesn't matter the data, doesn't matter what people say, but they now want to make sure they implement policies to keep people from rolling off of Medicaid because they've said it so much. We might have different reasons, but we have the same goal. We want less people to get disenrolled from Medicaid too. We leave aside that we might have different reasons and different motivations, but if we have a common goal, then how can we work with them to achieve their goal because it's still mutually beneficial? So it's like, also, can you put differences aside if there are common goals with folks that maybe weren't like-minded, but now a certain policy change has brought multiple stakeholders together from different angles? And it's like, how can you just focus on the goal and the outcome, and maybe not, everyone's personal reason or different reasons of why they came to the table?
A kind of somewhat related note for me as well. I think about like in academic research, I think that there have always been kind of comments on like what even does impact look like. I think that kind of traditionally it's been, all right, you pull up someone's CV, and if it's 100 pages, all right, that's someone who has impact. Or they have a million RO1 dollars, then yeah, okay, that's someone who has impact. And I think kind of a couple of different ways that's being dismantled. And I think it's always kind of the dissemination of those dollars has always kind of favored some types of institutions and people who come from certain backgrounds and pursue certain topics. And I think now more than ever, I think people are realizing, oh, hey, this might be unequally distributed. And so how are ways that we can kind of reassess what is an impactful career if there are some topics, scholars, whoever, who they might submit a proposal that's dead on arrival, which is something that maybe to a certain extent was happening already, but I think that's it's even more a conversation of, well, if there are kind of traditional ways of assessing what is a successful scholar, maybe it is someone who is participating in more advocacy. Maybe it's someone who's starting a blog. Maybe it's someone who's starting, I don't know. There's too many podcasts. I think that that shouldn't be the way forward for starting impact, but maybe it's appearing on an already reputable made podcast. I think about these different ways that people can kind of get in front of people who might not be hearing about their own expertise as a way that individuals are finding new ways to kind of get their work out there and reach some of the different communities. And I think that that's honestly something that I'm really happy to see because I think that it's something that is a different skill and talent that not everyone is meant to do, but I think that there's been kind of a void, especially amongst some of our I don't know, best and brightest, quote unquote. So that's something that kind of comes to mind for me.
Thank you both so much. I'll hold maybe another minute or two before we close up for any other audience questions or just reflections on tonight's webinar overall, or if any of our panelists want to jump in and add some closing thoughts before we end our discussion this evening. I'll kind of leave space for that as well. Okay. That's totally fine. If nobody has any other comments, we had some really rich discussion this evening. Thank you all for, our attendees for being here and for chiming in and joining the conversation, and to our panelists. You have been doing an amazing work in your own corners, and we really appreciate you taking the time to be here this evening to kind of talk us through what you've been working on and just kind of giving us a lot of hope and optimism as to how we can move forward as both just a profession within the health professions workspace, but also just in the different pockets of research and policy and advocacy and health professions education overall. So we're really, really grateful to have all of you. Attendees, for you all, if you'd like to see more of this, we are actually having another webinar on October 28th, Tuesday, October 28th from 8 to 9 p.m. Eastern. And the title of that is No Margin, No Mission, Sustaining the Safety Net. So we'll be talking more about kind of the safety net and how we can maintain that for our patients and communities. And then if you haven't already joined our mailing list, please do go ahead and do that. It's on our website, and you'll be able to get more regular updates from us, things that we're working on and any other initiatives that we would would love to have folks join or provide input on as well. And I'll pause there to see if Rob or Toyshay, if I missed anything in terms of other ways folks can kind of stay involved. No, from Toyshay. Rob, anything else?
No, you covered everything. Thank you all so much for this incredible conversation. I've been taking copious notes. And this information, like many of you alluded to, is the key to our survival over the next few years. And SMA is really dedicated to making sure that people have access to that information so that they can, stay on track relative to realizing the dreams they have for themselves professionally, in terms of how they want to be, a positive contributor to our society. So thank you all so much for the work that you do, and for taking the time tonight.